The posterior sickle is used for removal of supragingival calculus. The posterior sickle may be used to remove deposits that extend slightly below the free margin, but only when the tissue is inflamed and retractable enough to permit easy insertion. Sickle scalers are not suitable for complete scaling or root planing and should be followed by a curette for complete calculus removal. The objectives of this program are to prepare the learner to be able to identify the basic design features and areas of use of the posterior sickle, to practice the correct grasp, angulation, adaptation, and stroke used with the posterior sickle. The basic design features of the posterior sickle are the handle, the shank, and the tip. It should be noted that the shank has a contra-angle bend so that the blade, shank, and handle are not in the same plane, and the tip can be adapted to posterior teeth. The sickle has two straight cutting edges, each of which is formed by the junction of its face and a flat side. The sides join to form the sharp, pointed back of the instrument. The face and lateral surfaces of the sickle meet to form a sharp, pointed tip. These design features make the posterior sickle poorly suited for subgingival calculus removal and could cause laceration of tissue as well as gouging and grooving of the root surface. The posterior sickle is well designed to adapt to flat proximal surfaces in the removal of supragingival calculus. For this demonstration, we will be working the buccal surfaces of the mandibular posterior teeth. A firm, modified pen grasp should be used. Establish a fulcrum close to the tooth being scaled. Before inserting the tip at the distobuccal line angle, determine if the lower or terminal portion of the shank is parallel to the tooth being scaled. If it is not parallel, select the opposite end and recheck. Once you've selected the correct end, place the cutting edge just above the free margin, using only the last few millimeters of the pointed tip for scaling. Take care not to allow the back or tip of the blade to harm the tissue. The angle between the instrument and the tooth should be less than 90 degrees, more than 45 degrees. If you are scaling supragingival calculus, begin activating short, overlapping strokes in the area above the free margin by lowering your wrist and rocking back slightly on your finger rest. When the proximal contact prevents further movement of the sickle, carefully withdraw the blade and reposition it at the mesiobuccal line angle. If you are planning to remove a subgingival ledge of calculus, carefully insert the tip of the blade at the mesio line angle. Watch the back of the blade very carefully as the blade is inserted. Note, do not attempt to insert this instrument to the epithelial attachment. Insert to get onto the calculus ledge only when the tissue in the area is easily displaced. The working end of the posterior sickle that is used for the buccal aspect of the mandibular right posterior can also be used to scale the lingual aspect of the left mandibular posterior. Use a mouth mirror to retract the tongue. Practice holding the mirror with your free hand while positioning and using the sickle scaler. On the lingual aspect, the starting will be the distolingual line angle. In review, a few important points should be noted. Start on the distal-most posterior tooth and progress towards the anterior of the mouth. Always use a modified pen grasp. Use the terminal shank as a visual cue for end selection. Scale from line angle to interproximal surface. Due to the design features of this instrument, the posterior sickle should be reserved for removal of supragingival calculus and is not suitable for complete scaling or root planing.